Hello and welcome to all of you to this webinar on aHUS on behalf of NephroPlus, the Atypical HUS India Foundation, the Kidney Warriors Foundation, and supported by AstraZeneca. We're bringing to you today a very exciting webinar on atypical HUS. And without further ado, I'd like to introduce our chairs for today, Dr. Vivekanand Jha, who's the Executive Director of the George Institute for Global Health and also the chairman of the Scientific Advisory Board of NephroPlus and one of the leading clinicians and researchers from India. And I also like to introduce Dr. Arvind Bagga, who's one of the leading clinicians and researchers in atypical HUS in pediatric patients. And Dr. Bagga has been the head of department of the pediatric nephrology department in AIMS and currently practices at Apollo, Delhi. I hand it over to Dr. Jha and Dr. Bagga to take you through the webinar. Thank you so much.
Thank you, Kamal, for that very brief intro. And it's my pleasure to be in the company of Professor Arvind Bagga, who is really the expert here. I'm pretending to be an expert. I am a nephrologist, of course, and manage patients with the atypical HUS, which is a big problem. And I would like to, before passing on to Professor Bagga, give a shout out to Kamal himself, who is a person living with HUS and has shown great fortitude during the course of the disease and how he has fought with it. So at some point, perhaps you might want to share your own experience as well, but not in today's webinar, unfortunately, because it is so packed with activities. So keeping that in mind, I pass on to Professor Bagga, who has already been introduced, and invite him to start the proceedings.
Thank you, Dr. Jha. Thank you so much for your kind words, and thank you, Kamal, for inviting us to this meeting. We have a tight program, and we will begin with a talk by Dr. Nicole Isbel, who is a faculty and consultant nephrology at the University of Queensland and Princess Alexandra Hospital, Brisbane. She has lots of work on glomerulonephritis, C3 glomerulopathy, work on transplant immunology. It's great to have you here, Dr. Nicole, and to share your experience with us on early diagnosis and management of atypical HUS in adults and children. Thank you so much. Over to Nicole.
Lovely, thank you. I'll just share my slides. Are you able to see my slides now?
No, not yet. They haven't come through.
Okay. Yep, they come through.
Yep, that there.
Yep. Lovely. Thank you. Well, thank you so much for inviting me to come. And I am somewhat awed to present to your audience. And there are experts among you on aspects of aHUS about which I know less, such as the factor H autoantibody. But I'm going to try and reflect, and it's been a useful experience to reflect back on the Australian experience now that we've had just over 10 years of funded access to the CER5 inhibitors. So I'm just going to declare my conflicts of interest with both Alexion and Novartis and other complement companies. So I'm going to talk as much as I can as a practical aspect. I remember when I gave some talks in Australia during the introductory phase of these not new therapies at the time, and the things that were frequently asked and then subsequently what questions I was often asked. So I've tried to focus a little bit on that. And it really comes around to diagnostic dilemmas and treatment strategies and what is aHUS, or complement-mediated TMA, as it's probably more properly called, and then trying to drill down into what we've learned from the Australian experience, and then talk just a little bit about transplantation. So I'm just quickly going to run through a case that was highlight several things. One is this was a young woman who presented to a regional centre. So Australia is a large country with a fairly small population, and the expertise in treating rare disease is concentrated in the larger, usually coastal-based cities. But patients live everywhere, and they present to regional hospitals, and it's often a not thought of diagnosis. So part of the work that you'll need to do in the next 12 months is to refine your referral strategies and your diagnostic capabilities of your referring and regional centres. So this woman presented with a urinary tract infection, really, and was noted to have impaired kidney function and anemia and a platelet count which dropped, but didn't drop into the thrombocytic panic range, but certainly had fallen through from her presentation. This was all attributed to sepsis, although she wasn't particularly sick or septic, and she was treated with IV antibiotics. She got a bit better and she went home. Unfortunately, she re-presented to her local hospital again 2 weeks later, much more significantly unwell this time, with a deterioration in her function, lower platelets, and an elevated LDH. So we're kind of fortunate in our state of Australia in that LDH is reported routinely in all biochemical profiles, and it actually is probably the test that triggers people to think about it amongst all of many other causes of acute kidney injury. Having a markedly elevated LDH really became the trigger for people to start thinking about, well, maybe this is a TMA, maybe this is aHUS. So anyway, she was then seen by a physician who did consider that she had a thrombotic microangiopathy. And I remember getting this text at about, I was just coming home and it was 10 o'clock on a Saturday night. And people started ringing about this new-ish, well, it wasn't a new condition, but it was certainly a diagnostic a conundrum for people, and they started ringing for advice about what to do about these patients. And the primary question is it aHUS? What tests do I do? So certainly I actually recognised the patient's surname because we'd looked after her great uncle, I think, who had had a transplant, and it was one of those patients you remember forever because he'd had such a terrible outcome and a terrible course. And we had at that time developed a cheat sheet, which was very useful to be able to email out to your friends and colleagues at 10 o'clock on a Saturday night. So a practical tip is that many clinicians in your regional areas will know about this disease, but will be unfamiliar and somewhat uncomfortable in making the diagnosis. So supporting them, because they're your referral, unless you get this disease early and treat it early, the outcomes are poorer. So we also developed some national guidelines and set up some registries. We quickly joined the global Alexian registry, although that's somewhat winding down now. And I personally found that joining the registry was enormously productive for me, both in terms of research that we were able to do, but also in developing contacts and links with some of the complement labs in Europe, where a lot of the groundbreaking research has been done. So I think working collectively to develop national guidelines and registries is actually a fantastic opportunity for you to take now. So we published our consensus opinion piece in 2018, and it also had the benefit of bringing together people who were interested in the disease, who've loosely worked together both on this and C3 glomerulopathy over the subsequent years. You certainly need to do as much education as you can and target it to your regional hospitals, where the people who recognise and see the disease on the front line will be important in picking up and making the diagnosis and on referring. So I was speaking earlier to some of your faculty there, and I think there is a system of centres of excellence being developed in India, and it's an excellent way of going forward along perhaps the UK model. But the other models that are interesting are those that have set up things like TMA teams, so that anyone who meets the triad of thrombotic microangiopathy are seen by people who have an understanding of the disease within the hospital to rule in and rule out whether or not this might be a complement-mediated disease. Australia is a bit more casual than that. We've got the phone a friend kind of centres of excellence approach, which has served us pretty well, I think. And that fits in with our funding model, which hasn't mandated a more national approach, and it's worked for us. We've developed checklists to ensure that the tests are done and the tests are done right, so that you can try and effectively rule out some of the other differential diagnoses. So again, very quickly, just the key points from this case was that this was a girl who had endothelial damage in her kidney, possibly triggered by an episode of pyelonephritis. See many other triggers, IVF therapy, oral contraceptive pill, pregnancy, etc. She'd gone on to develop microvascular thrombosis and hemolysis. and with the triad of microangiopathic hemolytic anemia, thrombocytopenia, and LDH all displayed in her laboratory parameters. She had organ injury, in this case just really limited to her kidneys, but certainly it's all the blood vessels that can be affected, and it's you know, you always see something new when you see a new patient. We've seen people with cardiomyopathies, CNS involvement, pancreatitis, etc. And it's tricky because the biopsy often looks very similar regardless of what sort of TMA you've got. And the thing I've put up here is you can see these are the blood vessels, the efferent and afferent arterioles, and they're almost entirely occluded. So not only is it that there is a mechanical injury to the blood vessels causing the rise in LDH, it's actually often a marker of ischemia, of organ ischemia, as well as the hemolysis. So to get back to the diagnosis, and this is what you guys are going to see from here is that, you know, this is a rare disease when it's complement mediated, but differentiating it from the very common and multiple other causes of TMA is actually quite tricky, and to this day remains for us the most difficult part of management of this disease. So the step one, this is all basic kind of stuff. You've got to make the diagnosis of a TMA to start with, and you've got to think about it. And as I mentioned, the LDH we found to be a very useful way of getting people to consider that a thrombotic microangiopathy might be at play. But people are anemic, they're thrombocytopenic, they have schistocytes on the film. You need to ring the lab sometimes to make sure they're looking for them properly. The haptoglobin is reduced, etc. It's very important to rule out sepsis early on, or DIC, or other causes for that. We find that people sometimes forget to do the coag profile. Very important that that's normal. This is taken from our somewhat out of date now, perhaps consensus guideline, just in terms of the major and easy to think of differentials being TTP. And I guess the other thing about TTP is that the treatment of this with plasma exchange remains the first line therapy. It's very important that plasma exchange is instituted for TTP, and that if you do go to first line therapy with complement inhibitors for aHUS, that TTP is absolutely ruled out so that you don't miss an opportunity to treat that condition. Most of it's acquired due to an Adams TS13 antibody. There are rare congenital forms. STEC-HUS, I'm an adult nephrologist, so I don't see a lot. We see some, but not a lot. We've seen infection-associated HUS with pneumococcus and multiple other infections, CMV, HTLV, etc., and influenza we did see quite a bit as well. The conditions associated with TMA, or associated with things that can trigger a TMA, is ever growing. And I'll move on to this very nice review in the Lancet a couple of years ago, to which some of you have contributed, to try and then get the nomenclature a little bit clearer and the divisions very much clearer. But it also helps when you're looking at your differential diagnosis to go through all of these things that are associated with aHUS or a thrombotic microangiopathy, and just think about them. So do they have an infection? Could they be pregnant? Are they taking a drug which is associated with the condition? Transplant's a whole different ballpark, and it's quite complex. Antibody-mediated rejection, ischemia, reperfusion injury will all be associated with the TMA at times. And these secondary aHUSs, with the malignant hypertension in particular, does provide some challenges, and I'll talk just a little bit about that later on. There are these other non-complement mediated mutations in various genes which have been developed, been recognized over time, and they're also very important to consider, particularly in the pediatric population. So you'll have some different expertise amongst your pediatricians and your adult physicians about what they're referring and who has the disease. And I suspect it's actually probably easier to make the diagnosis in children once you've ruled out the STEC-HUS, as they are more likely perhaps to have a complement-mediated disease. Adults, the broad range of other causes of thrombotic microangiopathy really make it quite complex. So again, this is just our checklist. Again, you can make up your own. They're all the things that you would expect to do. We do a STEC aHUS stool culture if they've had any history at all of diarrhea, and we can do an Adams TS13 within 24 hours in most places in Australia now. So that's actually been very useful, and we need to remember to do that before you put them on plasma exchange. Otherwise, you're just testing the Adams TS13 on someone else's plasma. And again, we do a series of other tests, particularly the autoimmune antibodies in young women, and also not to miss things like antiphospholipid antibody syndrome, which can sometimes be a diagnostic concern. So again, just a few tips from things we've learned. If you can't get the Adams TS13, the French criteria or COPO criteria or the plasmic score perform pretty well, actually. And we use them now just as a rule of thumb when we're sort of going, oh, should they be admitted under renal or be admitted under hematology? So we use a score to send them off to the department that we think is most likely to have to look after them. And that's the calculator for the plasmic score here. Very easy to use and reasonably reliable. We do some complement tests, but I was mentioning this before. We are not a country of complement testing excellence, I would have to say. We have very limited complement testing. We always do C3 and C4, and I think that's useful. They don't have to be low. The C3 doesn't have to be low. But if you've got a low C4, it's a trigger that something else is going on and activating the classical pathway. So again, that's a really helpful test, I think. So low C4, think classical pathway, think something that's activating that. Lupus, sometimes monoclonal gammopathies, etc., can do that. We do test factor I and factor H, but not. We don't put a lot of weight on it, and we don't always do it. You need to remember to test before plasma exchange is started. The collection, particularly for these, and C5b to 9 in particular, to get the collection right, that it's on ice, transported on ice and centrifuged and then frozen. Otherwise, the test we have found to be really unreliable. It's not done in our centre, and so we have to do it as a send-away test. And the test has not been that helpful, I would have to say, probably because in the real world, collecting it is not done optimally. We've tried, but we just really haven't really perfected the testing of that test, I don't think. It's also really important to remember that even if you can measure factor I and factor H, there are two important things that we've learned. One is that you can measure the protein, but that doesn't make it functional. So you can have normal amounts of a dysfunctional protein, so not helpful. Also, they get consumed in these really sick patients who are often in ICU. Often you get activation of the complement pathway in any form of TMA, and you will consume these factors, and they will be a little bit below the normal range. So again, there are some caveats about how reliable and useful these tests are. If you've got them, great, but I don't find them to be clinical, and I certainly wouldn't wait for the results to come back, because it takes a couple of weeks for us to get these results back before we start a drug in someone who we had a high clinical index of suspicion that they had a complement-mediated disease. I'm feeling anxious about talking about factor H autoantibody disease. It's not common in Australia. We have not had great access to testing for it, and we have probably missed some cases, and I'm not going to talk too much about it. We do genetic testing. It still routinely takes 6 months to get a result back from a genetic test in Australia. They're publicly funded. You can pay to have your test done more quickly, but the publicly funded tests take about 6 months, and we always need to use appropriate counselling before we do them. It's important when you get a new case that you define the organ involvement. We've seen a lot of cardiomyopathy. We've seen quite a bit of CNS involvement, which is sometimes under-recognised until they have a seizure. And often that's something we look back and the warning was coming, that they were a bit more confused, and then they sometimes have a seizure. And as I said before, it can almost affect any other organ in the body, and we've seen just about everything. So this is again taken from our work, from our consensus statement. It's really just have a high index of suspicion about other organ involvement. Gut, in the factor H disease, gut involvement is common. We've had patients who've been on dialysis, who've had these grumbling gut problems for years, and then subsequently diagnosed later on as having a factor H mutation and gut involvement. And pregnancy, again, associated most commonly, but not always, with postpartum presentation in our experience, although it is certainly described to occur at any time during pregnancy. Just as a point, we don't routinely perform a kidney biopsy. Often they are thrombocytopenic, and you don't want to be sticking needles and things. And the biopsies actually just look the same, regardless of what the cause of your TMA is. It might give you some prognostic information. If the kidneys are completely destroyed, then that may be useful in terms of prognosis. But certainly in the short term, we don't hold out for doing a biopsy. We get on and treat. So the sort of some take-home messages about setting this program up for you is just, it is useful to have a checklist to mail your friends at 10 o'clock on a Saturday night. Make sure they know where to get the tests done, which labs are offering them, and that how to collect the tests, the on-ice issue, the before plasma exchange issue, and that hammering home that excluding STEC and TTP and the factor H autoantibodies, because they will alter what treatment you have and steer you away from complement inhibition for a large extent. So we've worked with our pathology colleagues to speed up the rate at which the tests are done, particularly things like ADAM TS13 and the STEC results, and that's now been very useful for us. And I think the dialogue with the laboratories has been quite productive. So just to get back, I should have probably started with a slide. It's rare, except TMA is not rare. So you'll see a lot of TMA and you'll have to sift through it to find the complement-mediated disease. Previously, it had been suggested that it was much more common in children. All of the registries now refute that, and in fact are largely, the balance is there's a large number of adults with the disease as well. In children, the gender or the sex differences, there's no sex difference. In adults, there are more women affected, probably because of the effect of estrogen and the triggering effect of pregnancy. It's a multi-system disease, and these patients are often really very unwell. There's often an environmental trigger, often infection, estrogen kind of provoking things, malignant hypertension, etc., can all trigger the disease. About 75% of the original cohorts had a genetic variation. There's been a lot of work done to refine what is a variant that is pathological as opposed to the many variants of uncertain significance. Again, I've highlighted the pathways here. This is a very old but very but neat and tidy kind of example graph of the complement pathways. So aHUS is a disease of the alternate complement pathway and variants or mutations that occur in the regulatory proteins. There's a combination of those that block the negative inhibitors like factor H and factor I, but there are gain-of-function mutations reported for things like C3, etc., and the membrane-based protein MCP. So again, knowing what mutation people have got is helpful. They behave somewhat differently. They have different recurrence rates post-transplant and a greater propensity to relapse, perhaps in the most common mutation, which is factor H. So again, anxious about talking about this. We don't see a lot of it, and I probably will skip most over this and I would be much more interested in hearing your own experience rather than our limited experience with this condition. So just to highlight that we do genetic testing. It takes too long for it to come back, but that's a systemic problem with genetic testing in Australia. It does carry prognostic information. It is useful for a while. We are still using it to determine when to stop, how long to treat for. So I think anyone if you can, in whom you start a complement inhibitor, getting the genetic testing to try and help guide your decision making is an important part of it. So historically, the prognosis has been dire, with 50% of adults on dialysis at the end of 12 months and a very high recurrence rate in the very pathogenic mutations with very poor outcomes. And certainly this is a very old slide, but showing just in the pink here the good outcome associated with MCP. Again, this is a frequently relapsing variant, but carries with it a very good prognosis. So that's useful information to have. Whereas red line here is the factor H mutation, which has the poorest prognosis, the most increased risk of relapse post-transplant. So I think, again, knowing these mutations and which one you've got is helpful. So now to get on to treatment. So I think consulting an expert centre to help with the correct diagnosis is absolutely essential. Plasma exchange has been the therapy of choice for a long time, where you're essentially replacing the missing gene products and things like factor H mutations, which are a loss of function mutation. There is partial efficacy with plasma exchange, and some people have been maintained on recurrent episodes of aHUS with plasma exchange for many years. For the gain of function mutations and the cell surface mutations, plasma exchange is not particularly effective. Liver transplantation had a vogue in terms of treatment. You certainly cure the underlying problem, as most of these factors are made in the liver, but there is a high morbidity and mortality, and certainly you actually probably need complement inhibition around the time of a liver transplant to actually get it to the patient to survive. The morbidity and mortality of not using complement inhibition and liver transplantation is very high. There's been a couple done in Australia, but not many, and we've really not gone down that pathway any further. You need to know if they've got a factor H autoantibody. The treatment's different. You can treat them with eculizumab, and it stops the complement activation, but doesn't do anything for the underlying cause of the disease. So eculizumab, game changer for this condition, monoclonal antibody targeting C5. The dosing for adults is given there. There's weight-based dosing available for children. The infusion reactions in our experience are rare. We've seen more infusion reactions actually with the pegylated ravulizumab version of this molecule. But certainly with eculizumab, we've had very few. It's possible and has been reported that there be allergic reactions, but they are uncommon. There's a whole host in the observational studies of side effects which are listed, but these is non-randomized, non-placebo-controlled trial reporting of whatever illnesses these people gathered along the way. So I think it's a safe and well-tolerated drug. Vaccination is critical. Antibiotic prophylaxis is important and needs to be emphasised, and patient education about the risks of meningococcal disease and early presentation when unwell are all part of management of these patients. I'll just skip over that. You block C5, you turn off the endothelial activation and the complement cascade, and reduce the production of inflammatory molecules and aflatoxins, C5a, etc., C3a. So just again, not to read through in detail, but this is the schematic taken from the original New England Journal of publication back in 2015 about the two non-randomized observational trials of use of eculizumab in patients who had aHUS. There were two groups. The things to know about them is trial 1 is that they had a much shorter duration of disease, and trial 2, these were people who were plasma exchange resistant, and I think that impacts on significantly on the recovery of renal function, as you'll see. So again, just in panel D, you can see this drug works. It blocks complement and it blocks it very, very quickly. You see a fairly nice and steady increase in platelet count, which usually occurs in the first 1 to 2 weeks. The renal function varies depending on how late you start the drug. So trial 1, when they had a much shorter time before they were treated with disease, you can see about a median increase of about 35 mils per minute in GFR, which occurs over months, probably out to about 6 months, sorry. In trial 2, where they had much more severe disease, the actual increase in GFR by the end of the trial was only 10 mils per minute. It tells you something about how you should get on and treat the disease as early as you can. So just a few practical points is that eculizumab works. You need to stop the plasma exchange, or because you'll just exchange it off and waste it, and you'll have to give them an additional dose. It's mandated that we do not use plasma exchange in patients who are getting this drug in our institution. If the hematology is not getting better in the first couple of weeks, rethink the diagnosis. That's one thing we have found to be very useful, is that the platelet count should get better. If it's not getting better, then you may have the wrong diagnosis. If the GFR is not getting better, over months, that may be because so much damage was done to the kidney that the recovery is not possible. But certainly the hematology should improve, and patients feel better, and their quality of life is much improved. So that will leave you with so many questions, and I'll quickly run through just a few other tips that have come up that we've learned along the way. So indications for use will vary according to access and cost. There are many places around the world that have a much more liberal use of the drug, and we will continue to learn from their experience. In Australia, we have to rule out STEC and TTP as part of our process, but if they have a high likelihood of a complement-mediated deficiency, we will actually use it as first-line therapy, universally in children, so they don't have to have a line inserted for plasma exchange, and in many, but not all, adults. We start therapy, but then we'll stop rapidly if we think the diagnosis, something comes up, we make the diagnosis, alternative diagnosis, or the genetics come back and they do not have a mutation or they have a low-risk mutation. And TMA in the presence of triggers is super tricky, and I've just put up a publication by some of my other Australian colleagues in nephrology, which is actually quite nice, and I really liked their very pragmatic approach to hypertension and TMA, pregnancy and TMA, drugs and TMA, just so that it gives you something to look at and work through. So actually, so this was a panel across many Asian countries where they all contributed a consensus opinion. So when to start? As soon as you can is my, if you think you've got ruled out the other conditions and you have a complement-mediated disease, the sooner you get on with it, the better. And I think that this is just the overlay of those two graphs from the original trials, which show that there's quite a significant difference in recovery of function in those that had 8 months of disease before they actually got access to the drug. So how quickly should the renal function improve, or the other things? This is one of the questions I got asked very quickly. Is it working? Is it working? So you should see normalization of the platelet count in 1 to 2 weeks. You hopefully will see a maintenance of their GFR and an improvement in their renal function, provided they don't have such severe disease or it's so late that they're not going to get recovery. LDH should come down by a month as the ischemia, probably hemolysis stops, but then they've just got resolving ischemia and what other organs are affected. And certainly by 6 months, you should see maintenance of renal function. You may or may not get small increments of benefit after that, but possibly not. And I'll just skip that bit because that's an old slide. And this is actually the recovery of the patient who we spoke about earlier. So you can see that she did get a little bit of plasma exchange while we're sorting things out and got things organised. Her platelets came up nicely, her creatinine improved, and she actually did very well. So it is a game changer. It has decreased the incidence of end-stage kidney disease, certainly improved the outcomes post-transplantation and reduced the risk. This is some unpublished data from Australia where we've just reviewed from 6 treating hospitals the eculizumab use from our funded program. So we got good at this. We were making a diagnosis within 4 days. These are the people who were treated. We don't know who wasn't treated and who didn't have a diagnosis made. So there is some bias in terms of the data. There were 25 patients on dialysis at commencement and 78% of them came off and GFR improved, and I'll show you a picture. We had no meningococcal infections. We've discontinued 70% of this time and had only 1 relapse. And possibly as we get more comfortable with it, most of them should come off, and at least for a trial. So you can see here from this graph that the creatinine improved substantially, GFR improved, hemoglobin came up quickly, LDH, etc. So all the things you would expect from this drug. So what about stopping? There's been a lot of work in the Netherlands and the UK and Italy about how you can consider stopping this drug. And I can just like to just point out the thing to take from this is the blue bar here is the no variant, and you can see that those who have no mutation, that the recurrence of TMA is almost 0. So again, that's the low-hanging fruit. They're easy to stop. That's simple. The univariate predictors of relapse are more common in females. If they've had relapses before, more likely past behaviour predicts future behaviour. If they have a CFH mutation, they're more likely to relapse. They're more likely to have impaired renal function with that group, as opposed to the MCP mutation, which is a frequently relapsing but not particularly pathogenic mutation. So eculizumab in that study was restarted with good outcome, and just about everyone got retained whatever GFR they had lost, and it saved many, many, many millions of dollars. So again, the Netherlands have mandated that there be early withdrawal, and I won't go through their detail of their data. It's very similar. And the UK have just published a Markov modelling study suggesting that treatment withdrawal and monitoring was cost effective and probably improves quality of life, because you're then not having people come into your hospital for infusions every 2 weeks, or even if you're on ravulizumab and longer intervals. So there probably is a considerable financial and social benefit in stopping. So we start if it's likely to be complement-mediated. We stop if we find another diagnosis. We could talk a little bit about when you stop. It's variable, I guess. If there's no mutations or a variant in a non-complement gene, then we'll stop fairly quickly. If they've got low-risk mutations, we'll stabilize them for a few months and then stop. And if they've got a high-risk variant, a number of our patients had severe disease very early on and didn't have access to drug until their transplant, and they are very reluctant to stop. And we have never forced anyone to stop. You can keep on it in Australia, it's okay. We're trying to encourage them to stop, but they don't always want to, and that's fine by us. You need to make a plan for monitoring, particularly in the setting of a triggering event, and you need to be ready to go again if they relapse. So transplantation, we're seeing many fewer patients come to transplant now because they're not ending up with end-stage kidney disease, which is a wonderful, wonderful outcome. And certainly the outcomes have improved post-transplant. This is some work I was involved with the global aHUS registry, which really just shows that if you know you have the disease, you're on eculizumab, you get transplanted, that your outcome is excellent, and it's probably not any different really from any other transplant candidate. If you go for rescue therapy, it depends a little bit on how quickly you can access the drug. The outcomes here were not as good in our rescue therapy group, which was group 2, but they certainly did better than those that had very late diagnosis. Similarly, this is from the UK group, which the red is prophylactic eculizumab versus their historical controls, and you can see there's an excellent graft survival. So unfortunately in Australia, we don't have access to preemptive use or prophylactic use for eculizumab. So we do try and do a bit of stratification, and if they've got a high risk or it's their second graft, or we can get time-limited access through compassionate access through AstraZeneca. We have used rescue therapy, but there is complexity about this, and it's very important to point this out, I think, our local experience of rescue therapy. We've seen a lot of extrarenal manifestations, gut, CNS confusion in patients. We've seen renal limited disease, conversely, and it has been very subtle. One patient had to have multiple biopsies before we could actually prove that she did in fact have recurrent disease. She had a less pathogenic mutation in C3, but she had progressive loss of graft function. She'd lost a graft before due to recurrent aHUS. So it took us a while to make that diagnosis. And we had another case where the endothelial injury was quite severe and it precipitated untreatable antibody-mediated rejection. We lost that graft before we could even access eculizumab for her. The meningococcal infections, very important. There's probably a 5 to 2,000-fold increased risk of meningococcal disease. It's very important that you vaccinate. We've got 2 meningococcal vaccines, pneumococcus, Haemophilus, etc. Can start before the vaccination is completed. It's very important to use antibiotics. So just some other questions we get asked. What do you do if someone's on eculizumab and they have an infection? We get them started on treatment and we don't hold up the eculizumab, particularly in that early phase while they've still got a lot of complement activity floating around. Been a number of pregnancies now. It's safe. It's been both used in the PNH population and the aHUS population without any concern, and it's also safe to breastfeed on the drug if that's what's required. So really, that is a bit of a tour around the Australian experience of aHUS. We've learned a lot about the mechanisms of complement activation within the kidney and in endothelial surfaces. You do need a high index of suspicion. You'll see TMA everywhere when you first start this, and weeding out who you need to treat in a cost-effective way is probably the trickiest part of the whole deal. It does work. It's a game-changing medication for those who have the disease, but that careful and considered withdrawal is cost-effective and safe. And just finally, I wanted to plug the transplant meeting, which will be the International Transplant Meeting for TTS, which will be in Sydney next year. Just want to make sure that you all know you're very welcome to attend. And thank you.
Thank you so much,
Right.
Nicole, for excellent talk, comprehensive and a detailed exposition of all this finer points in management of HUS. We have a tight schedule, but I'll still take a few questions that the audience has asked. The one question, Nicole, is that do you treat patients with CNS TMA differently? So patients with neurological symptoms, would you manage them differently? And are there any risk factors for relapse for a CNS disease?
We would not, well, we might treat them more aggressively and quickly if they have got CNS involvement. We tend not to use eculizumab in STEC-HUS at all. We have occasionally done it when we're desperate with people with terrible STEC-HUS CNS disease. I'm not entirely sure that it's of benefit. The trial data's mixed. So that's one thing. And then in terms of predictors, the people we've had who've had CNS disease have often had very severe hypertension and severe volume loading as well. So that would be the key thing. We've seen it a little bit in those that have been post-transplant. Again, if they're on a calcineurin inhibitor, there's probably some synergy between endothelial activation from the tacrolimus. We don't have access to belatacept, for example, so we're committed to calcineurin inhibitor-based therapies for transplants.
The other question, Nicole, is that other than atypical HUS, other TMAs, for example, pregnancy TMA, should we be using eculizumab? Because that's also a very difficult question. I agree, because given that you have HELP and then you have preeclampsia. So when would you use eculizumab in pregnancy TMA?
Yep. So again, it's the sum of the parts. I guess we're looking for things that rule in or rule out the other diagnoses, I guess, for HELP, etc., and the liver function tests and so on. The timing, you can get TMA at any time, from HUS throughout a pregnancy, but the ones we've seen have tended to be postpartum, which was what was originally reported, but that is not always the case. If you deliver the pregnancy and the hemolysis continues for more than 3 or 4 days, we'll start them at that point, so that if the TMA is not resolving, and I guess this is across the board. Same with hypertension, malignant hypertension. If you control the hypertension and the hemolysis is continuing after 3 or 4 days, we're very suspicious then that they have a complement-mediated condition, and then we'll treat them with eculizumab at about that time point.
You did address one question with when do you expect the counts to improve, and you did say that the platelets would come back to normal within 1 to 2 weeks. And this would be true for virtually all forms of atypical HUS that you encounter?
Yes, it is. So much so. Oops, sorry, I'm echoing. So yes, so much so that if we don't see the platelet count improve, then after a couple of weeks, we're really suspicious that we've not got the right diagnosis. Doesn't mean it's not 100% predictive, but certainly we are looking widely to see if we have missed something else that's going on.
Okay, thank you so much. I think we'll go to the panelists for some question answers, and we'll come back to you for the case presentations. Thank you, Nicole.
Okay.
Thank you so much. Could we have the slides off, and could we have the panelists So we are, it's great to have 5 panelists.
Dr. Nicole, if you could just stop sharing your slides, please. Dr. Nicole, thank you.
So Kamal, we have Dr. Aditi Sinha, we have got Manu Dogra.
Yeah,
Dr.
Dr. Bagga has just messaged that he's not going to be able to make it, Dr. Bagga, but we
don't
can.
worry. And Dr. Raju is there.
Yes, he's there.
And is Dr. Bhattacharya is there
He's
as well.
also not there. He's not there. But we have Dr. Saili Thakre as well.
To Shaili Thakre. So, okay. So thank you so much for joining. So we just have 3 panelists, you're saying.
Yes, 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 sir.
So I'll probably not, we'll keep Dr. Manisha and Raja for the case discussion. So we will not probably call them in for this. So, so we'll begin with Dr. Raju first. Dr. Raju, when you're faced with a patient with atypical HUS, are there any mimics that you are worried about that you would want to exclude before you start thinking about HUS? Dr. Raju.
Don't think Dr. Raju is online.
He's not online. So, so Aditi, could you address this?
Yeah, so especially in pediatric populations and in a country like ours, we do face difficulty in diagnosing hemolytic uremic syndrome or thrombocytopenic purpura. Our chief concerns are around excluding mimics, which are typically in this season or earlier would be the tropical infections such as dengue, malaria, leptospirosis, which could scrub typhus, which could all have the triad of anemia, thrombocytopenia, and AKI. And the key is to identifying microangiopathic hemolytic anemia and the persistence of the hemolysis beyond the treatment of the infection that has triggered it. The other entity that you need to be wary of is sepsis, disseminated intravascular coagulation in other infectious settings, particularly so when you're making the diagnosis of pneumococcal HUS. One has to be careful to be sure that you're not confusing the DIC associated with the active invasive pneumococcal disease with the HUS per se. The other entities that we would want to consider, obviously, HUS is a diagnosis of excluding TTP in the appropriate clinical setting. And for that, you would need to use the plasmic criteria or just kind of a sense of having disproportionate thrombocytopenia out of proportion to the degree of AKI. With or without multiple organ system involvements, including neurological infections. Dr. Bagga, you could add on to those.
Thank you. Thanks so much.
Dr. Raju is now available. Dr.
Yeah, Raju, thanks for joining.
I'm online. Yeah, thank you. Sorry for the delay.
No, don't worry. Raju, when would you think about doing a kidney biopsy in a patient with atypical HUS? Because the practice is slightly different in adults compared to children. So what would be the indications for a biopsy in a patient with atypical HUS?
So when we suspect strongly with all the other features of suggestive of MAHA and as other features of suggestive of HUS, we can actually start off the therapy after sending in a sample for Adam TSH. Then we'll wait for platelet count to be normal, at least 1 lakh. 1 lakh and above, sometimes we have done around 1995 also we have done, but around 1 lakh and above is safe, and we will be very comfortable in doing the kidney biopsy. And sometimes we had a problem with our hematologist saying that when it's clinically so strong and clear, why do you want to do a kidney biopsy? I know that actually this is the question which we had around 10-15 years back when we were strongly suspecting, but we were unable to prove. That time the concepts of atypical HUS and doing the biopsies and following it up and giving the therapy was actually very it's not available to us, and it was the farthest stretch of imagination that some drug would come in the future and where we can think of atypical HUS in a significant way. So, but we went ahead with the biopsy, provided the platelet count is at least minimum of 1 lakh. But whenever the creatinine is very high, when some of the slides also showed that when you have an alternative form of a diagnosis, then you are supposed to. So we are supposed to do the biopsy to whenever there's an atypical presentation and also a systemic disorder, to know that it is not just an atypical HUS alone. And sometimes the severe infections, otherwise also can, initial stages, it can mimic the atypical HUS-like feature. That's why we are supposed to do a biopsy and see them. And adults, especially in adults, it is very, very important, because Malignant hypertension, sometimes it looks as if it is the same kind of a thing, but we had a problem between malignant hypertension, which comes almost in the similar fashion, and also HUS. And we found some of the patients genetic analysis totally haywire, and we could not even correlate them by any other means. So when this kind of a situation comes, we are supposed to do biopsy. But biopsy is an indication in almost all the cases where the manifestations are there, unless it becomes normal with no proteinuria immediately. But in a good number of cases, probably in adult population where we are practicing in a center, which is the highest referral center, by the time they come to us, we would land up in doing a biopsy. In a few cases, we have not done the biopsy because of the platelet count, but otherwise, there should be an indication.
Okay, thank you. Thanks. I think that's an important point, because in children, we hardly ever biopsy. 95%,
yes.
We would hardly. Dr. Jha, would you like to comment on this? Professor Jha?
No, nothing else from me on this.
Okay.
I suggest we move on with other questions.
Yeah, we have multiple questions. Doctor, who else do we have? Dr. Thackeray. Dr. Thackeray, so can I ask you, that Nicole did mention that there was limited role of measuring levels of factor H, factor I. What is your experience? Would you be keen to do these studies, or you think they probably don't mean very much, and genetics is what it matters?
Thank you so much, sir, for the question. And thank you, Dr. Isbel, for the wonderful talk. Regarding genetics and complement studies, we, as of now, are restricted to doing more of anti-factor H levels. And so far in our experience, we have found that the disease activity quite correlates in a substantial number of fraction of patients. But there are examples which come to my mind where the factor H levels are very high and the patient has had cycles of relapse, remission, relapse again and again, and they absolutely have not correlated with the factor H levels as well. But by and large, the majority of them do correlate. I would be at a loss for a percentage to quote a percentage. I'm sure, sir, you will be able to throw a light on this as well. And genetics as well. I think our Indian experience is more about the anti-factor H positive disease rather than the genetic variant predominant disease. And most of it is factor H. And we keep recurrently seeing CFHR heterozygous mutations like deletions or duplications. Very few homozygous. They are after factor H mutations, they are the most common. But we also keep seeing this heterozygous variant on and off again and again in this subset, which remains to be, though we disregard it most of the times.
Dr. There's a question linked to this, So there's a question from one of the participants. A 19-year-old patient having homozygous deletion of CFHR1-3 without factor H antibodies. Native kidney disease is not known. Patient is on dialysis. Can the patient undergo transplant? Precautions.
For this question, I would like to probe into the history of this particular patient regarding a family history of any renal disease or atypical HUS-like disease or illness. I would look at the age of the child. If the patient has passed childhood without having any triggers of HUS and has passed through into adulthood, probably this may not be relevant to the future prognosis. All the more, I would still like to proceed with transplant, but with continue monitoring at a closer interval than usual. And accepting familial donors will also be an issue because it's inherited. So in getting a father or a mother to donate, they would also require to get a genetic testing. But nevertheless, as of now, I think that's what at least we follow in our practices. We do accept these recipients and donors as well. With an index of observation that's closer than most if they had not had this variant. We do consider this as a variant.
I would probably just add, that do remember that 10% of the Indian population is CFHR1-3 homozygous deletion, shows CFHR1-3. So we have no idea that how many diabetics we are transplanting who have CFHR1-3 deletion. We have no idea of how much hypertensive kidney disease. So to me, and maybe Dr. Jha could comment as well, that CFHR1-3 deletion outside of anti-factor H autoantibodies perhaps does not mean very much. Nicole, would you like to comment on this?
Yeah, I think that's become the accepted kind of teaching now about that deletion. So yes, we would observe it, but not give it any credence as a pathogenic mutation.
Okay. Aditi, the last question to you. There were lots of questions on anti-factor H autoantibodies. So in the current state in India, how would you best manage anti-factor H autoantibody associated atypical HUS?
So given the large amount of data that has accrued through registry-based collection of information on anti-FH associated HUS within our own country among children from the subcontinent, we believe that managing them with plasma exchanges and immunosuppression seems to be a better, definitely an evidence-based strategy to manage it, because we have now information from this registry that you have started and we have continued to enter patients into, that indicates that using plasma exchanges brings down the antibody titers acutely, rapidly by 95-99%. And within 5 to 7 days median time, patients would enter disease remission, which means platelets would normalize. And renal recovery is achieved in the majority of patients in whom therapy has been initiated in a timely manner. Adding on immunosuppression logically is supposed to reduce the titers of antibody by reducing their production. And with the removal through plasma exchanges, this approach had been used and has been followed. So what we would do is plasma exchanges, prednisolone therapy, once having confirmed antibodies, give IV cyclophosphamide as the induction immunosuppression similar to vasculitis and other, we have started with that approach, and then carry on immunosuppression with mycophenolate mofetil or azathioprine, and take off the prednisolone first and later the mycophenolate mofetil. The disease relapses are typically in the first 2 years of the disease and usually do not follow afterwards, although we have seen in the COVID pandemic remote relapses also. So vigilance would be necessary, but beyond the first 2 years or so, therapy may not be required. Monitoring of titers is important. Besides that, the eculizumab experience is rather limited, sir. So we still need to do some head-to-head comparisons in this regard.
Thank you, Dr. Aditi. I think our time for panel-related discussion is over. So we'll now move on to the case discussions, and I'll request Nicole, Manisha, and Raja, Dr. Raja Ramachandran, Manisha Sahai, and Nicole to take over the case discussions. Thank you so much. Raja.
Yeah, thank you, sir. Sir, I would request Dr. Nicole and Dr. Manisha to, initiate the proceedings, and maybe we can have the case presentation one by one. For the Dr. Manisha and Dr. Nicole, please.
Yeah. So, Dr. Nicole, would you like to proceed, or I'll just start it? So, thank you, Dr. Nicole. Yours was an excellent presentation with all the practical points and has helped resolve some of the queries the participants had. So now, and the panel discussion was also good and brought out some of the points which were, which were in addition highlighted to your presentation. So that was also good as well. So now we'll move over to the third aspect. That's the case presentation. And the first case presentation, I think, would be by Dr. Sayali. Sayali is presenting the first case, is it?
Yes.
No,
yeah, so Dr.
Sandhya Suresh, Dr. Sandhya Suresh, first case.
Okay, Dr. Sandhya would be presenting. Yes, sorry, I'm so sorry. Yeah, so Dr. Sandhya, I think you're there online. Yeah, yes, so we'll move. So we have three case presentations, and we have tried not to keep them overlapping. So they are short case presentations, and Sandhya would be taking the first case. So Sandhya, over to you.
Yes. Are my slides visible?
Yes,
yes, they are. Yes, they are visible. Yeah.
Thank you. Good evening, everyone. So I will be presenting about a challenging case of anti-factor H associated hemolytic uremic syndrome. And this case dates back to March 2025. We had a 5-year-old female child admitted in the pediatric ICU with fever for 2 days and history of abdominal pain and reduced urine output following this. On examination, her BP was 120/70, which is about the 99th centile for her age and height. And she also had periorbital edema on admission. On admission, her hemoglobin was 4.4, her platelet count was 62,000, her creatinine was 6.4 at presentation. She also had mild hyperkalemia and acidosis. Her urine showed a proteinuria of 4+ and RBCs of 255. Considering the presence of anemia and thrombocytopenia with the rapid renal failure, We did a further evaluation and that showed a retic count of 7.3 with LDH elevated to 3,724. A peripheral smear showed 5% schistocytes. C3 was low. A respiratory viral panel was done, throat swab was done, and that showed a respiratory syncytial virus positivity. At this point, we thought it is most likely to be a TMA. We sent the ADAM-TS13 activity levels and the anti-CFH antibody levels. And this was her trend of her reports. You can see that the blue line is the creatinine and the orange line is the platelet count. So this was how it started off with the creatinine being 6.4. She required about 4 sessions of dialysis. We started off plasmapheresis as soon as she was admitted, and daily plasmapheresis was done for about 20 sessions. From day one, there was a slight rise in platelet count. It went up, but never went up beyond 1 lakh. This was despite optimum plasmapheresis at 1.5 plasma volumes. And in spite of the platelet counts going up, it did not go above 1 lakh after the first week, and it started dropping after, in spite of daily plasmapheresis sessions after the first week of plasmapheresis. She also had other features of ongoing TMA with high LDH levels and persistent schistocytes on peripheral smear. She also developed refractory hypertension despite the plasmapheresis. She required about 5 antihypertensives, including minoxidil. She had seizures, and the MRI brain showed features of PRES. At this point, by about day 10, we labeled it as refractory to plasmapheresis and decided to broach the topic of eculizumab. However, due to logistic constraints, due to cost, there was a delay in the procurement of eculizumab. Meanwhile, the anti-CFH antibodies that we had sent came about a week later, and it was very high. It was 10,000 AU per ml. And we had initially started her on steroids with pulse methyl prednisolone followed by oral steroids. And on day 14, we gave her injection cyclophosphamide as well. We continued the daily plasmapheresis till the eculizumab was obtained. And on day 20, you could see that eculizumab was given according to her weight, which was 600 milligram for the first dose. And following this, there was a rise in the platelet count. And subsequent dose of eculizumab was given 1 week later. And her platelet count normalized, and all the other parameters like schistocytes became negative. Her LDH normalized, retic count came down. All of these factors also improved. This was the algorithm that we followed from the 2019 paper published by Dr. Bagga in about hemolytic uremic syndrome management in developing countries where eculizumab may not be easily available. So based on this, we started her on immunosuppression along with plasmapheresis, and after 10 sessions of plasmapheresis, we planned to give her eculizumab. Her genetic tests were done. Whole exome sequencing showed no pathogenic variants. MLPA was done, which showed CFHR3 and CFHR1 heterozygous deletion, and a susceptibility allele associated with the phenotype was identified. And this was her further progress. So in March was her initial presentation, following which she was continued on eculizumab for about 3 doses. About 3 months of eculizumab was given, totally about 6 doses. And at that time, that only the imported version of eculizumab was available. And the cyclophosphamide was given monthly, 3 doses were given, after which she was transitioned to MMF. She remained in remission for about 6 months. Her antihypertensives were gradually reduced. Her renal function completely normalized. However, she had persistent 1+, 2+ proteinuria with a urine protein creatinine ratio of about 0.6. She was continued on enalapril. However, her anti-factor H titers continued to remain high. You can see that even in spite of continuing immunosuppression, the anti-factor H after 6 months was about 6,500. So we kept her on very close clinical monitoring once in every 2 weeks. However, in October, she had a fever. She had fever with cough and cold, which was diagnosed as influenza A and had a relapse. So in October 2025, she presented to us with fever, cough and cold for 2 days. On the day of admission, her hemoglobin was 11.7 and her platelet count was 2.67 lakhs. However, on day 2, the hemoglobin started dropping. Platelets also decreased to 47,000. Her LDH was found to be 900. Her peripheral smear showed schistocytes with a low C3. The respiratory viral panel throat swab showed influenza A positivity. She was immediately started on eculizumab, after which she achieved hematological remission. Within 2 days, her platelets started rising. In view of the persistently high anti-CFH titers, she was given 2 doses of rituximab, 500 milligram per meter square, a week apart, and she's currently on continuing doses of eculizumab. So this was a recent publication in September 2025 from IJN, where there is a guideline for eculizumab administration in atypical HUS, and this is what we were following for our child. She had already received meningococcal and pneumococcal vaccinations before her first presentation. She was only continued on antibiotic prophylaxis. The challenges in this case were that she has a severe onset with very high titers, more than 10,000, and with persistently high titers despite multiple immunosuppressive agents. She maintained normal renal function but had persistent proteinuria, and she had a relapse which was triggered by viral infection. So some of the questions that I wanted to ask the panelists were, should we target the reduction of antibody titers, and what is a meaningful reduction of antibody titers that we should be targeting?
Thank you, Dr. Sir.
Yeah. Yeah,
Thank you,
Raja, go
Dr.
ahead.
Yeah. Thank you. Thank you, Dr. Sandhya, for the nice case presentation. Before we take the question, I have only one doubt, this patient was administered eculizumab, right at the time when the platelet count started an uptick. So, that's one doubt. And regarding the question, with respect to antibody, I think I would pass on this question to Professor Bagga and Professor Aditi for the same, because they have the most experience among all the panelists over here. So, sir, I think you can take this question.
Thank you, Raja. So it's odd, such high levels, are normally not seen with anti-factor H disease. And even in your case, even on after the 6th plasma exchange, the levels were still almost 11,000. So clearly you began with very high levels. Because with 6 plasma exchanges, the antibody level should come down to about 10% of what you began with.
This was sent before the plasmapheresis.
I agree. So clearly these are very high levels. And normally our practice has been to just continue mycophenolate. There are very few studies or very few case reports wherein people have combined eculizumab with cyclophosphamide. So in case you decide to use eculizumab, then I think the other immunosuppressive agent should probably be mycophenolate. And you give this for perhaps 2 years. Nobody knows the precise answer how long you give, but you give it for about 2 years, keeping in mind that the risk of relapses is highest in the first 2 years. And whenever you have a relapse, you'll have to manage the relapse either by plasma exchange or by the anti-factor H, anti-factor 5 inhibitor. We still, as a routine, would be doing plasma exchanges, and they do serve the purpose in most cases. That's all what I have to say. Yeah, Raja.
Yeah, thank you so much, sir. Thank you so much. Your other questions were, Sandhya, you had 2 or 3 set of questions.
Yes. In this patient, she maintained remission in spite of the high anti-factor H titers for almost 6 months.
Yeah.
It was only after the influenza that she had a relapse trigger. Should we be targeting the reduction of antibody titers in the first place, or would it be enough to just do a clinical monitoring?
I think just clinical monitoring is fine, and we don't try to, aggressively, there are no strategies to reduce the titers. And clearly, people have used various strategies. One would keep a watch on the titers, and as you've written rightly, any titer above 1500 is perhaps unsafe.
Yeah.
One can do a soluble C5b29 further to see whether there's activity. But as Nicole said, estimating C5b29 is dicey, and it depends a lot, how rapidly do you do these assays and so on. So overall, you just keep these patients on long-term immunosuppression, and they would tend to do well. But I must say, that even in this group of patients, with using eculizumab, the outcomes are perhaps similar or even better compared to Plex alone. So I think eculizumab will have a role even in anti-factor H disease in a group of patients.
So here I would just like to ask Dr. Bagga and Dr. Nicole, what time in such patients where you have antibody positive, would you start with eculizumab? I mean, what is your policy? I mean, adding eculizumab in such patients, that's question number 1. And in pediatric TMAs, would you routinely screen for, the cobalamin C deficiency and the
Nicole, would you want to go first?
Yeah, sure. It's so interesting because it's the reciprocal. We see so little of this, and I'm an adult, so we would get the factor H autoantibody back, a few weeks after we'd started treatment with eculizumab, usually because the prevalence in our population is so low. So we have used it inadvertently in patients who have factor H antibodies, and it worked just fine. And then we've gone on. They didn't have such high levels. It was a bit of an atypical case. It was an older patient rather than a younger one, and they got some immunosuppression with rituximab and actually did very well with that therapy. So I have much less experience in this condition because of the differences in prevalence in our country. So we certainly had efficacy with eculizumab, but similarly we also did with it. We gave the rituximab, the antibodies came down, we stopped the eculizumab.
So the Indian guidelines did say, Manisha, that one should consider rituximab if after about 7 exchanges with plasma exchanges in anti-factor H disease, you don't get hematological remission. Normally, hematological remission would happen by day 5, day 7, maybe by the end of first week. So, or if you've got some other genetic variant, which is extremely rare. So we have not used eculizumab in most cases. Having said that, if you do have a patient whose thrombocytopenia is persistent, given the fact that we have access to this agent, it could be considered. One does require a head-to-head trial, though, because it's such an important thing. And I'm sure, Nicole, anti-factor H is much more prevalent worldwide than we ascribe it to be. So clearly, it's perhaps more common.
Yes, sir.
Yeah.
Thank you, sir. So, okay, please, Nicole, go ahead, please.
Oh, no, I was just going to say, whenever the registries and real-world data is looked at, the amount of testing for factor H autoantibody is not 100% by any means. And when we looked at our cohort that we've just looked at, the number of people who didn't have the test was just too high. So there is a message in our populations to get out there that the test needs to be looked for, because, yes, you think the prevalence is low till you actually start doing the testing properly.
Yeah. So we have the hands raised from Professor Jha, then Dr. Sayali, and then Dr. Sinha. So please.
Yeah, look, in my opinion, I think we are skewing this discussion towards the antibody titers. That's really not, as was mentioned already, not something that people have access to on a day-to-day basis. So our clinical discussion should be primarily focused towards the traditional ways in which we can look at activity and response, which is, active hemolysis, platelet counts, etc. And where available, I think the antibody levels is a luxury and can help guide further fine-tune the treatment. But I think the primary guide to therapy should still remain what is most widely available.
Okay, sir. Sure, sir. Dr. Sayali?
Yes, sir. So my question is to Dr. Bagga and Dr. Nicole. Is there a possibility that anti-factor H antibodies, for example, in the case that Sandhya presented, the levels remaining high, but clinical remission gets achieved? Is there a possibility that this is an epiphenomenon more than the pathogenicity of the antibodies? Does that put a question to the pathogenicity of the antibodies if we observe such cases? I myself have a case with a similar high level of titers, but patient keeps having cycles of relapse and remission. I've not measured a C5b9 to actually prove whether the disease is active when the antibodies are still high. But Dr. Bagga, sir, what do you think about this?
I think the pathogenicity of the antibodies is reasonably well established based on the way the antibodies act on factor H by binding to the C-terminal. Having said that, you may have a patient who's doing perfectly well, but having high titers, not as high as what were reported by Dr. Suresh. But clearly, you may have titers like 1,000 or 1,500. And I think one would follow up these patients clinically. And as Dr. Jha said, maintaining a hematological remission, but keeping in mind that during infections, be on the alert. whenever they get an infection, be aware that this could be a relapse. Even if you don't have access to antibodies, you should be looking out for relapses during intercurrent infections.
I was just going to say one thing, just in terms, it's like this with all of both the mutations and the antibodies, is that it's a balance, a seesaw between what's happening on the endothelial surface and the ability of the system to regulate it. So it is, I guess, possible that you can compensate, even though you have got pathogenic antibodies in a state where the endothelium is happy and the factor H can control what's going on. But as soon as you tip that by any sort of trigger, and influenza is a common one, or any other viral infection, is that you then overwhelm the system to balance that out. So I think there are similarities. People have a factor H mutation and they're fine for years and years and years and years until they meet the trigger that sets them off, and that balance is disturbed. So I wonder in this case whether something similar is occurring.
Yeah, Dr. Aditi, I think you have your hands up.
Yeah, sorry, at the cost of prolonging this, my 2-3 just points. One thing, Dr. Sandhya, where were you measuring your antibodies? Because we don't expect antibodies to linger after so many plasma exchanges at that high titer. We expect them to be below 500 or so. That was one point. Second was that, I mean, if you have within 6 months a relapse, I would think the strategy failed. I understand that relapse was defined in terms of hematological activity and not just the titer. Third thing was, I mean, now that you haven't had a relapse and you embarked on eculizumab, would you ever be able to get off eculizumab? Because you have not done plasma exchanges right now. So had you done plasma exchange, you would have the titer down, and maybe even 1,000 titer lingering in future may not be a problem, but a 6,500 titer lingering into future would never leave you at rest, at least if this is done in the right manner.
So these levels were done in KEM. They were sent through Lalpat from our own hospital. And this was done also in another couple of patients. And in those patients, the levels did come down. So in this patient, we repeated the titers also in another lab through Apollo. And that was also the same titers.
I'm sorry, I mean, I don't want to come off as anything else, but just, the titers, we have seen patients with titers swinging from 10,000 to 400 and back. Without any clinical changes. So depends on where you're testing. Professor Bagga, would you want to just last word on this and please move on?
I think we should move on to the next case. I think we probably have time for only one case. Raja.
Raja, you're on mute.
Muted.
Sorry, all. We have Dr. Sayali for the presentation. Dr. Sayali, please go ahead. Then we have Dr. Arun after.
No, Dr. Raja, I think the case is by Dr. Arun, not...
Arun.
Okay, then fine. Yeah.
So Arun, try to do it in the next 10 minutes. We need to...
Yeah.
We're almost time to close, So,
okay.
10 minutes of case and then about 3 minutes of discussion.
Can you do the case in 5 minutes, Arun?
Yeah, I think he will be.
I didn't want to say that, Yeah.
Just a minute. Yeah. There's some issue with the sharing. Yeah.
So, good afternoon. So I'll complete it fast. So my focus is currently today's case is pregnancy AKI. Yeah. So we had a 30-year-old female who was nurse by profession and got recently came. It was a primary gravida who came at 30 weeks of gestation with 10 days clinical history. So, but she was a booked and immunized case, and her kidney functions, proteinuria and kidney functions were normal, both pre-pregnancy and during the early trimesters. So she presented with edema and increase in blood pressure. Her blood pressures were 180 by 110 millimeters of mercury. She had seizures. There was decrease in urine output, and there was some proteinuria. So clinically, she was diagnosed as a case of pregnancy-induced hypertension, that is eclampsia, and she was admitted under intensive care and was managed by obstetrics and intensive care people. So she underwent an emergency cesarean section on day 1 of presentation, considering the fetal distress, and the ultimate outcome was a stillbirth and abruptio placentae. By the time she got operated after the surgery, she became anuric and she became dialysis dependent. Then we probably thought that her blood parameters and the pregnancy-induced hypertension changes would improve with delivery, but the other things happened, like the hemoglobin from day 1 dropped down to 5 over the next 5 days, and the platelet count was constantly decreasing from 85,000 to 45,000. The LDH was high, and the cystocytes blood smear showed 7% cystocytes. Contrary to the HELP syndrome, we had the liver functions which were fairly okay, but still the OT was high. ADAM TS13 was done that time itself, and it was normal. So we had a diagnosis of microangiopathic hemolytic anemia. She had some blood loss during pregnancy. We did transfuse, but still the hemoglobin drop was not accounting for whatever we were managing. So we thought that some amount of, not some amount, the predominant thing which is happening now is the microangiopathic hemolytic anemia, and probably the C3 levels were low, C4 levels were low, and we got the alternate pathway activity, which was later reported as decreased, and soluble C5 B to 9 were elevated. Both the reports we came to know it later, but the complement levels were low. So we started on her on plasma exchange at 1 plasma volume for 5 continuous days, and subsequently her hemoglobin improved from 6 to 9.6, and the platelet count improved to 220,000. There was partial recovery in kidney function, but the hemolysis part had settled, so we discharged her by day 20. Now the contrast CT, which we usually do in patients who have completely recovered or partially recovered, did not show any evidence of ACN, though her urine output had improved by then. So we did her follow-up for her for the next 2 years. By day 30 in our AKI follow-up clinic, so she presented the kidney functions had almost improved, but we checked her complement levels, which were normal. Anti-factor H antibody was sent, and it came out to be negative. At day 90, her blood pressure significantly improved. The renal functions became normalized, started normalizing. During the next follow-up of 2 years, she was evaluated for the etiology of the previous TMA episode. So she was diagnosed to have, the reports came as ANA was 2+ positivity, and it was homogeneous. Anti-Rho and anti-Jo antibody were positive. Jo antibody is an associated with anti-synthetase syndrome, but she did not have any clinical features to suggest connective tissue disease, which was odd in her case. So at presentation, we had done a Coombs test. It was slightly positive, the anti-IgG, but subsequent reports were negative. APLA was negative. Complement levels were subsequently checked again and again, which were normal. The proteinuria was not there. So she, as she was willing for a pregnancy, so we had advised her on with continuous monitoring. The genetic testing was done after counseling for complement genes, which were all negative, and also for high-risk pregnancy. The obstetric team, they did their own genetic testing, which were negative from their side. So the second pregnancy was monitored. She was close to our hospital. She took hydroxychloroquine as a prophylaxis for the antibody positivity. She was also taking aspirin. But this time, even though she was nearer to our hospital, she was completely normal until 32 weeks, when she started developing increase in blood pressure again. The proteinuria started coming up, and creatinine was slightly high. The LDH was high. There was increase in there was evidence of microangiopathic hemolytic anemia, but cystocytes were not seen this time. The complement levels were normal. Probably she was better managed this time, but she delivered a child, but the child had a postnatal death. The cause remains unknown until now. Maybe the possible etiology may be the transfer of antibodies, but it is not sure. So my case summarizes a subclinical connective tissue disorder, which has not yet clinically shown, except the fact this is presenting as a preeclampsia, which subsequently went on to thrombotic microangiopathy. The first pregnancy was probably not fairly managed, or she presented late, and it went on to be a frank thrombotic microangiopathy. And the second pregnancy, she was with us, and she was better managed, and she did not have overt TMA. So we did not do a kidney biopsy in her at any point of time, but I have two reports of placenta, but the first one showed a frank infarct and the second one showed just placental insufficiency. So as Dr. Nicole pointed out, we were very particular about the collection of samples for complement. So we had formed we discussed and we formed a timeline at which we have to draw samples, how to keep, and we excluded many samples which were not properly collected. Subsequently, we considered patients with pregnancy-induced cortical necrosis. So this was our data set, where most of the patients with cortical necrosis, unfortunately, the presented patient, fortunately, the presented patient did not have cortical necrosis, but all these patients have cortical necrosis, and we have been doing the complement testing, and we have all seen is that the complement is highly activated and there is heavy consumption. The C3 is low for most of the patients. There is the red line, the red color indicates the consumption of, which is abnormal, the consumption of complements. So we are just analyzing, but we have seen heterozygous and both homozygous mutations. So the points of discussion would be like whether the pregnancy in TMA in this case is a continuum of the connective tissue disease, and how should we manage for the pregnancies. Thank you.
Thank you all. Thank you, Dr. Arun, and we can have some questions.
I can make a couple of comments. That is an extraordinarily tricky case.
Yes.
And I'm not sure that I certainly don't have a diagnostic answer for you about what this woman's got. But I would like to make a comment about the complement assays in someone who is so sick and has a thrombotic microangiopathy. You just get consumption of complement regardless of what the trigger is. So yep, I'm not a bit surprised that you're finding that there are markers of activation of complement. Is that pathogenic or a consequence of the severe illness is less clear, I think. I would think. That's just a comment on the complement assays. I think they're going to be low and you get consumption of them anyway. So lupus and other autoimmune diseases are fascinating. I think we are only just starting to learn about all of the targets that antibodies could be made against. And I don't know what antibodies she's got. Her C4 was normal at other times, is that right? She had always had a normal C4?
She had normal C4 throughout.
Yeah. So I don't, yeah, I don't have an answer. Maybe someone else who is on the panel would have an answer for you for what the pathogenic mechanism of this disease is. Do I think that her pregnancy-induced hypertension is a spectrum? No, this woman's got something that is very pathological. I don't know what it is, and I think that a third pregnancy, gosh, if she wanted to go around again. Oh, that would be very difficult. If she was desperate to do it, you could potentially, if you could access it, give us some eculizumab from some point on. But that would be just speculative. I've got no evidence at all, and I in fact would be asking other people who are more specialist in pregnancy-induced disease. The French group in particular have done lots of work on this.
Yeah. Thank you. Yeah, your point's well taken. This patient during her first pregnancy, she had antepartum hemorrhage, and that was probably the trigger for, developing kidney dysfunction in this patient. Whereas during the second pregnancy, she did not have these kind of triggers, and, it was more of controlled. She was managed in a controlled setting. So probably that's the reason she did not have this degree of thrombotic microangiopathy during the second pregnancy. If you look at it, there was some drop in the hemoglobin, but there was no schistocytes. LDH was also reasonable. So I presume that, most of the pregnancy-associated TMA, you will see that they are associated with some degree of compromised clinical care, either bleeding, infection, these are the triggers which are well known for complement-mediated diseases. I think one factor that could help assist is also whether the TMA had started or was it all pre-eclampsia and then the complement TMA is, doing SFLT-PIGF. If you have an SFLT-PIGF, that may help. If you have a very strong SFLT-PIGF starting from the second trimester going on to the third trimester, you could be reasonably sure that there is probably a pre-eclampsia also in this patient, which is probably predisposing to, the complement-mediated TMA.
Yeah, your complement markers before they get sick would be much more helpful than after they get sick. Yep.
So Dr. Raja, in this, we also see a lot of pregnancy AKI, and generally most of it is preeclampsia, and by 72 hours post-delivery, most of them recover. And as the literature also says that post 72 hours, if there is persistent AKI, and again, the pictures, the microangiopathy and all. So those are the times when we think of aHUS, and literature says that around 50 to 80% have complement defects. But in your case, I mean, apart from the deletions, you did not have any other major complement defects. Is that right? Is that what you showed in the slide? The genetic pattern was otherwise okay. That's what you said.
There was no, the whole exome sequencing was fine, and also there was no duplication or deletion in any of them. So that was a clean. And only thing is, what we didn't show is CFH levels were low and CFB levels were also low, which probably is because of the consumption of the TMA. Because of the TMA itself, you could have a low CFH and CFB levels. And so
this lady was transfused as well. I mean, 5 gram hemoglobin, and she received 4-5 transfusions as well. Exactly. So all these factors were collected upfront before everything was done.
Yes. Yeah. We collect, during our, as a part of a project, we just collect the samples right at the time of diagnosis. We lost close to 100 samples because of poor collection. That is why we are standardized the way we are collecting now. So what we do is we collect and sample them and keep them in small vials, so that every time we take, we use it and we just throw it off, so that we don't thaw them again. There is no freeze thawing done in any of the samples.
Okay. Thank you. But literature reports a lot of complement defects. In fact, our pregnancy AKIs, we are also having some sort of similar findings because genetic is now available to us freely. So we are getting it done, and most of the times what we are getting is what you showed. So CFHR, those are the things we are getting. Other things, no.
I think CFHR, I think most of the times you will have a CFHR deletion in more, 1/3 to half of the cases.
Yes,
I think they are not very significant. They are as good as a negative finding in our population.
Absolutely. Yeah. So that's what our finding is. We are not finding any other defects except for an Indian population, like either heterozygous or even if homozygous VUS. Those are the findings we're getting. So and the serum complement levels, anyhow, again, there are many lacunae in the ways we are sending them to different labs. So I think still much more work needs to be done in this area. So Dr. Bagga, I mean, do you have experience with pregnancy AKI? I mean, I know you are in the pediatric field, but what would your take be on that? Because literature says that in some of the papers, even 80% reported complement mutations, 50 to 80%, it's that high. But in our experience, what Raja says, we also find the similar thing.
See, we don't see all these patients, but I must say that the overall rate of picking up a genetic cause in Indian children with atypical aHUS who are antibody negative is at best about 20%. One thing that we don't seem to look at very carefully are the hybrids in the CFHR 1 to 5 region. And I'm sure that there is a proportion of hybrids that we are missing. We require better MLPA and more sophisticated genetics. for people who are looking at this, and some lab, hopefully over the years, would come up. And Nicole, I think, wants to have a comment on this.
Yeah.
Yeah, we missed a big deletion and had to go back and rerun the MPLA. And again, that's one thing I did want to make the point of. So if you've done genetic testing back, a couple of years ago, it's always worth getting it rerun to make sure, if you're really suspicious and you think that there's something about this that looks like a complement-mediated mutation-driven disease, is rerunning your genetics and re-looking at it, because we certainly have been burnt having missed a big, huge deletion in one of our cases.
Dr. Nicole, here I would just like to ask, in Raja's case, suppose you were the treating physician and the lady came to you the second day after delivery, would you have started her on eculizumab after collecting all the samples? I mean, the reports came late, but they didn't start on eculizumab. What would you have done? Would you have done that?
Yeah, certainly. Again, I don't do any obstetrics medicine anymore. And the cases that I get asked about, they are, often there is something else that's triggered this. Fetal death is a huge trigger, abruption, sepsis. We have to make sure they don't have DIC sometimes. They haven't thought to check for that, repeatedly and sort of infection and retained placenta. So a lot of the times we are asking them to do that sort of stuff. But after 2 or 3, 4 days, if there's nothing happening, we would give them eculizumab on the basis that, again, I'm going a bit off script here, is that it is, and you've shown this, there's so much complements being activated that if you can interrupt the circle, of activation and endothelial injury, then maybe you are actually doing them some good in turning the process off. Again, that is all very controversial and up for debate.
Yeah, thank you. Thank you. I think, Dr. Manisha, I think we'll stop with this. I think we had a very nice discussion. Thank you all. Thank you, Dr. Sandhya and Dr. Arun for the nice case presentation. Over to you, sir. Bagga, sir, please.
Thank you, all the panelists, Manisha, Raja, Dr. Raju, Dr. Saidi, Aditi, for being here, and obviously to Nicole for being our guest speaker for today, and really setting a very high level of tone for the talk. I'd also like to thank Kamal for organizing this excellent meeting, and I'll hand you over to Kamal now. And thank you so much. Have a great evening.
Thank you so much, Dr. Bagga, sir, for chairing this webinar. Dr. Jha, thank you so much for chairing this webinar as well. And on behalf of NephroPlus, the Atypical HUS India Foundation, Kidney Warriors Foundation, and AstraZeneca, I thank all the participants, all the panelists, all the speakers for joining us today. Thank you. Good evening. Thank you so much, Dr. Nicole, as well, for doing the keynote. Your address was really enlightening for the entire audience. Thank you so much.
Thank you.
Thank you. Thanks, everyone.
Bye.
Thank you, everyone.